The USDA goes a little further and actually defines food insecurity by level. So if you're very low food secure, that means that you're hungry. If you're food secure, there's a continuum that they use to describe food insecurity. And actually there's a scale that we used in our research to measure food insecurity in our participants. So I just bring that up because it is kind of nuanced. I don't know that this would surprise anybody, but sometimes I'm surprised by this, but communities of color are at least twice as likely to live in poverty as white communities. And a lot of that, I'm sure, as you've learned over your education, is due to redlining, racism, and unfortunately, food insecurity is a symptom of, I would gather to say, racism. And so, when you look at the trends over time, there was an increase in food insecurity during the recession. It then leveled out to about like 10.5% of the general population. And then it's peaked again during COVID. So just looking at the rates over time. So our study also looked at and confirmed what Feeding America noted, is that, when you look at other factors related to food insecurity, you also see a correlation with unemployment rate inside of that community, poverty rate inside of that community. So in addition to, the demographics of the community, there's also a correlation with those things, which I don't think is surprising. What's, I think, worth noting is childhood food insecurity is projected to go up, especially in our region, to around 28%. Children are the most, they're hit the hardest by food insecurity, unfortunately. And what this also does not show is that, yes, although we could say that there was like a 10% food insecurity, average, that was for all populations. But if you look at Hispanic and Black populations, the rates are higher, going back to the communities of color statistic. So I spoke before my slide. So I've done these so much, I just know them. And unfortunately, because of COVID, we're seeing food insecurity rates go up. So in our regions, we're projecting it's about 2 to 3 times greater of a need right now than there was prior to COVID. And North Carolina is one of the hungriest states in America, unfortunately. And so 1 in 3 North Carolinians actually experience food insecurity. And so sometimes I do some local presentations, and what you're seeing are the 12 counties that are represented by the study that we helped to lead.
Did you have thoughts on inflation also impacting the pandemic, really? Yeah.
We finished that up prior to the whole inflation, unfortunately. That study was finished about 6 months ago, so maybe 8 months ago now. So that was before inflation really took hold of us. At this point, I'm even saying I might be food insecure, given how expensive everything is. But no, we did not account for that, unfortunately. If you're interested in how that report looks, or some of the things that it addressed, it's very food system oriented. There is a lot of focus on local food systems and how to integrate that. We are actively talking to county commissioners, city councils about some operational strategies they could use within their own counties. So it's an interesting food system assessment that I'm not sure that a lot of regions have done. So happy to share that link via email if that's easier. So going into, okay, well, what does food insecurity actually do? So I've already alluded to this, that, and I don't think this surprises anybody, but is linked to diabetes, hypertension, cognitive impairment, functional impairment, and actually premature mortality. And questions why. There's actually a lot of theories and modeling around this. So we would say, yeah, diet is one of the pathways to a chronic health condition. So it's understandably that you're going to eat higher caloric dense foods, higher sugar content in foods when you can't afford to eat more nutritious foods. And then there's also other pathways to think about. So in communities of color, there is, especially in areas that suffer from oppression, there is toxic stress. And so what has been found is that when someone is food insecurity, that is considered toxic stress because there's no control over the types of food that you want to buy for your family, or even the ability to get to foods in some cases. And then when you think about healthcare behaviors, so I specialize in older adult care, as you had heard, and actually specifically I do home-based primary care. And what we're finding is that some of our older adults are, and this is again no surprise, is they'll choose to feed their animals or their grandchildren before they feed themselves, or they'll just choose to forego buying medicines for themselves in order to afford food. So those sorts of interplay, the diet, the stress, and healthcare behaviors all interplay to cause chronic health conditions. So it's a little bit more complicated than just your diet. A local survey was looking at, oh no, I'm sorry, this is Feeding America study. I'm going to go into a local survey, but what you're seeing here are coping strategies. So older adults who report being food insecure, these are certain things that they may try to basically afford food. So buy the cheapest food, pawn items, may do a garden, may receive help from other people. And something that I've seen a lot of older adults do is water down their drinks. So if they have orange juice, for example, they'll put a lot of water in that orange juice to make it last longer. These rates were before the pandemic. I should probably update them, but food insecurity rates before the pandemic was about 8.5% North Dakota, about 20% in Mississippi. And of course, the number of older adults in 2017 that were food insecure were about 5 million. And unfortunately, those numbers are going up.
So, Dr. Zimmer, you had one question in the chat. What are the specific criteria for determining food insecurity versus insecurity?
Versus insecurity?
Yeah, yes, security versus insecurity.
Oh, security. Yeah, so I'll get into that a little bit. There's a 2 hunger screening question. So it's a pretty simple screening. It's validated, and it's just a quick way to say, have you had trouble affording your foods, and have you had trouble buying foods for your family? So it's a very simple measure, but most of the time, it captures whether or not someone is food insecure. So it's a pretty easy question. I go into that a little bit later. If you really want to drill down into the levels of food insecurity, there's a validated food security scale that you can use, but there's about 10 questions on it, I think. And so it's a little bit more involved. So that in clinical practice, the two, I can never say that, the hunger survey is the best way to go about that. This was the local survey that I alluded to. So in our local town of High Point, there was a survey done for older adults who lived in an underserved community. And one thing that I found most striking about this survey was that regarding their role in the community, about 44% of the older adults believed that they did not have a voice. And I felt that was pretty concerning, that they feel disempowered in their ability to change their situation. Addressing food insecurity. Oh, goodness gracious. I think about this way too much. So there was a great review that Dr. DeMarcus did. She's a family medicine physician through UCSF, and she looked at 29 studies of interventions done by either, community partnerships with healthcare institutions in general, or just CBOs. And she wanted to see what is actually the evidence that's out there for addressing food insecurity, what measures were being used to determine its effectiveness, and what are the outcomes of the programs. But unfortunately, there was a lot of mixed data. People were not using validated instruments in many cases. People do not measure the outcomes of the programs in the same way. And so what she was finding is there's some mixed evidence for doing food referrals and using vouchers with some improvement in food insecurity. It seemed as if home delivered meals had the strongest evidence. Seth Berkowitz is a researcher here at UNC Chapel Hill, and it's his research that she alludes to in this being the strongest evidence. He's done a pretty good job of capturing ED and hospitalization utilization, and also diabetes health outcomes related to home delivery of meals, and specifically in the older adult population. And then one thing that's really worth noting for clinical practice is that active referrals are more impactful than passive referrals. And so what that means is if you have a patient who identifies as food insecure in your clinic setting, giving them a list of places that they could go to for food is actually not very effective. But doing some navigation or connecting them to a social worker on your team or nurse navigator to help them kind of navigate what might be the best option for them is more impactful in practice. So just something to keep in mind. When you're trying to do—
Dr. Zimmer, can I just ask a quick question? I haven't been able to stay on top of everything, but I know that in the last administration, they defunded Meals on Wheels. Do you know if money has been reallocated to that particular program?
Mm-hmm. Yeah, so that's a great question. ARPA has some funding specifically for home delivery of meals to older adults, so they are revitalizing the funding. You're right, Meals on Wheels lost about 8 to 10% of its funding during the last few years, which is significant. And they were barely making it as it was. And so it's good to know that ARPA has put some funding in. It's interesting. ARPA had noted that what you see here, this collaboration, there was a lot of this during the pandemic. So people started collaborating across sectors. And I think the White House kind of took note. And the ARPA funding is not specific to Meals on Wheels. It's actually asking for innovative ideas around home delivery of meals for older adults. And so there are people across our state, at least, that I've been talking to that have really been trying to think about how do food councils interact with local farmers, interacting with food hubs, and potentially insurance companies and health sectors. So we make the case that you should be collaborating across sectors if you're trying to think about food insecurity on a larger level for sustainability purposes. But anyways, I just say that to say Meals on Wheels is receiving increased funding, but it's not the only funding it's not the only area now that that can potentially be funded. So just something to note. So I decided I wanted to try something myself, and it actually was interesting. So I have a really good friend who's a pediatrician, and she and I had two separate grants. Hers was through a local foundation and mine was through a local foundation, but they're separate foundations. And we had received that funding in 2019. So it actually helped start a market. We were going to start help a local CBO start a market. And so we do community-based participatory research. And so I said, well, let's do some focus groups to kind of plan out what that could potentially look like. So as you can see, we started that right when COVID was getting a foothold in America, and we didn't know it yet. So we had done about 4 or 5 focus groups at that time. We've actually published those focus groups, and I have the publication at the end. And then we decided actually in March that oh, we probably should just do some home delivery. And so we reached out to both of the foundations separately and said, could we just transition this into a home delivery program? At the time, the geriatric research team had actually been unable to work. So they were looking for something to do, to volunteer and make a difference for our older adults. As I had alluded to, I'm a clinician in our home-based primary care program, and we already were looking at food insecurity and other social determinants of health within our program. So we already knew who was struggling, but I actually had the medical students call each one of our patients and see who was now having problems accessing food due to the pandemic, because they were losing caregivers, et cetera, during the pandemic. And then so what we started doing was more of this ad hoc sort of, delivery program with volunteers, grants, and I think we raised like $30,000 from the community. And keep in mind, we never asked our participants to pay for anything. So this was all provided at no cost for our participants. And so at the beginning, our cohort was kind of a mixed group. We had some households with children that were geared more toward Dr. Montez's practice. She's in pediatrics. And then we also had the older adults that were geared, from our gerontology side. But we really wanted to try to look at the data. As I had mentioned, data is important. So we struggled. We finally got IRB approval about 3 months into our program to look at some of the measures of our program. And we wanted to measure food insecurity. I was specifically interested in depression and loneliness of our participants, especially for our older adults, because as you know, during the pandemic, the rates of depression and loneliness spiked, especially for older adults. And then we also measured fruit and vegetable intake, which is the USDA had done during one of their studies. And so we wanted to do that. So we formalized it a little bit more as we went along. And then funding stopped for the households, and we transitioned them into the market model because the market did open during the pandemic. And then only our older adults were receiving produce and meals going into like the September 2020 area of time. And I mentioned that because we actually started working with a local farmer. It was a woman-owned farm, and she would procure produce from other local farms and urban farms, and then make a box for us. So it was a $25 box. And then we had Second Harvest Food Bank prepare meals that were geared toward older adults. And so they had this mixed delivery of meals and also produce. And then I also had hired a couple of drivers and a social worker, and she would check and make sure the patients had DME, et cetera. And I think I explained some of this along the way, but just giving you an overview of kind of what we did and how the program changed over time. So we did some mixed methods research. I told you about the focus groups. We also did some semi-structured interviews of our participants, and we did some PDSA around our program as it went along. So we had some weekly survey data as well. We have published on the focus groups. We're trying to publish on the quantitative outcomes. And then I'm working on the semi-structured interview paper now. So happy to share any of that data. And what you're seeing is some of the outcomes that we were looking at. So the focus group data just overall didn't tell us anything that we really didn't know about, except for the focus groups were really interested in produce boxes at baseline. And we're also interested in like cooking classes. And so we kind of adapted our program to include a nutritionist. So we had a nutritionist calling participants, and we had a health coach who would call them because of course we couldn't get together to do cooking classes for our participants. So we had like this newsletter that would go out to them and, teach them about some of the produce that was in their boxes. These are all the partners it took. You're seeing New Communion as a is a ministry run by a Black pastor in town, and he would deliver on our behalf. Love Out Loud would help with getting volunteers. Enterprise Center is a shared kitchen used by Black business owners who want to, start their own restaurant businesses, so they would make meals for us. Second Harvest Food Bank. Providence Kitchen trains chefs from communities that are underserved, and they were providing the meals and making the meals for us. Fair Share Farm is the farm that worked with us. And then of course we worked with urban and regional farmers. And then Hope of Winston-Salem is a local nonprofit that feeds children, and they allowed us to use their cold storage space and packaging space and trucks to deliver the meals. So we had a pretty good group of partners. I don't know if we have time for the video, but I think I can talk as it's rolling.
You're doing well on time.
Okay, so let me see, because I'll have to share the video screen.
So that was extensive and quite impressive, your partnership process.
Oh yes, we've had some really great partners, and we continue to work with them, so we're excited. Okay, so you can see this video okay?
Yep.
Okay, good. So what you're seeing here are the farmers putting together the produce for us. And so these are our produce boxes. And I always told our older adults that their produce looked better than my produce. And whenever there was a leftover box, everybody was scrambling to go get it, because we always loved the produce that came in the boxes. So the farmer actually does microgreens as well. And so we actually got an opportunity to teach a lot of people about how to use microgreens. We always included a protein source. We did not deliver meat, but we always delivered eggs and milk. So there was so much milk. We actually inadvertently started local food hubs. So if a person in the neighborhood had too much food, they would start just giving it to their neighbors. And I just thought that was kind of an interesting phenomenon. They were at some points telling us that we were just giving them way too much food. And I just told them that, this was what we had to do with our funding. So give it to other people if you have too much. I thought it was a good problem to have. So you're seeing the meals there, and the nutritionists worked with Second Harvest Food Bank and Providence Kitchen to try to tailor the meals as much as we could. Meals like that cost about $5 per container, so you can only do so much with that amount of money. To do an organically based meal, you would need about $6 to $8 per meal. So you're seeing our social worker and coordinator. This is one of our drivers, Larry, and that's our other driver, Sharon. And so what you're seeing is them just kind of getting ready to deliver on behalf of our program. I will say, when we ran out of funding, everybody was really upset with me. And at the same time, they all want to remobilize if I'm able to restart the program. But it's been really hard to find a sustainable way to keep something like this going. So I just was driving myself crazy with grants, honestly. But that's kind of the gist of how our program worked. All right, let me go back to the PowerPoint. Okay, and then what you're seeing here, you can see that okay?
Somehow we have just a bar of the PowerPoint. I'm not sure. I think I just glitched on you.
Okay, let me try again. How's that?
There you go.
Okay. And then you're just seeing the front of our recipe, newsletter that we would give them. So on the back, we would put games and tips and that kind of stuff. We also did vaccines through our program. The healthcare provider and me just couldn't let that go. So we figured we were delivering meals anyway. So when the vaccines rolled out, we just brought the vaccines to their house and provided the COVID vaccines through our program. We continue to work with our community partners and other efforts. So you're seeing a list of those other efforts. And then I have 2 medical students that are Schweitzer Fellows who are wanting to start a medical student volunteer-based program to provide meals again for older adults. And so we're talking about some more sustainable ways to go about that. We delivered over 7,000 produce boxes over time. The QI PDSA cycles that I told you about, they actually helped inform what produce we would put in the box. Over time, we were able to put things in there that people really enjoyed. And then over 20,000 meals were provided. And then again, I'm just listing our partners. This is just kind of one of our patients. This is not their actual picture or name, but we did have a gentleman who had had a stroke, and his wife was his caregiver, and she had noted that he was not able to eat or chew effectively. So we tried to be mindful about putting produce in their box that she could boil down or turn into a soup. And we always put something like applesauce in his box. He actually died while he was in our program. But we were able to reduce them from low food security to high food security during our program. So I just thought that was a great kind of testament to our work. And she was talking about the microgreens when she said this, but she said, never had any lettuce that tastes so good before. So it was kind of fun to introduce people to that. One thing I'll note is we did not require someone be in the study to be in the program. So, you know, we started trying to capture some of the measures for our participants, but if someone wanted to be in the research to help us with those measures, that was fine. If they didn't, that was fine. So we did not require anyone to take a part in the measures over time. But for the people who did, we were able to change food insecurity over time. So what you're seeing here are the different levels of food security. And by the end of the program, we did a pretty good job of addressing food insecurity. And we did this over 18 months, but I'm just showing kind of a 6-month span of time just to kind of see, you know, the dosing of how long would it take for a program to really, we didn't see a lot of movement at 3 months. It was really 6 months that we saw movement for food security. And then again, this is after 6 months, you're seeing that the number of servings of fruit and vegetables did go up. It doesn't go up much. I've always been struck by this. The USDA study also noted that it went up by like 0.2 cups per day. And I'll say anecdotally, I had some patients that I actually was their primary care provider who actually were in this program, and I've taken care of them since the program stopped. And I watched their hemoglobin A1C go from, 10 to 6.5, and now they're back up in the 9s again. And so it's been interesting just, anecdotally to watch that. So I don't know if it's accurate that they're only getting 0.3 cups per day more, but it's just something that was noted. And of course, what's most meaningful to me and to our partners were what people had to say about the program. So you're just seeing a few little quotes from participants who were in our program. And we actually had another patient who had died during our program, and her son reached out to us and just said how meaningful the program was. And our volunteer was actually the last person that had seen her. She had died in her sleep, and he was just saying how grateful she had been for the program and how happy she was that day. And so I don't know, it was just very meaningful for us to hear some of the feedback from our participants and their family members. Oh, you're seeing some, I'm sorry, this is a busy slide, but these are our semi-structured interview feedback. And so we haven't published on this yet, but you're just kind of seeing some samplings of what people noted in each of these domains. So we asked about financial well-being, we asked about eating habits, we asked about kind of the barriers to food access, and then its impact on social isolation. We found that having consistent drivers go to their homes, which is no surprise to anyone, but especially drivers who look like them, was really helpful. And I don't think I included this, but we found that depression and loneliness scores stayed flat and even improved a little bit during our program, which was pretty impactful. It wasn't statistically significant, but it was pretty impactful, especially during COVID when everybody's rates were going up. And we didn't see that bump for our participants. Oh, there you go. So that's the hunger vital sign. So the questions are, we worry about our food running out before we have money to buy more. And then the food we bought just didn't last. And we shifted that from the last 12 months to the last 6 months. So I adjusted a little bit because of the rapid changes during COVID. But the official survey is the last 12 months. And you should be looking at this. Technically, you're supposed to be addressing or asking about social determinants of health every visit. Now, I see patients every 1 month, and I don't need to ask them every month. So I would say every 3 to 6 months, but just so you get an idea of the cadence of those sorts of questions. And a lot of that's for destigmatizing these types of conversations. I think sometimes clinicians feel like there's a certain stigma around addressing and talking about social determinants of health. And so the first thing is to be able to identify someone who's living in food insecure households. There are some constructs to just basically say, okay, what are some proven ways and strategies to try to address it? Again, I had mentioned active referrals. I feel like in a clinic setting, that tends to be the most utilized or at least potentially utilized way to go about it. A lot of people are really interested in community health workers helping inside of clinic spaces. I really like community health workers. I think that they do a great job at connecting people to resources, and in many cases they're from the communities that they serve. The other thing that's really underutilized is assisting with SNAP applications. So you may have known that as being food stamps, but SNAP has received increased funding, and a lot of older adults actually don't use SNAP as much as they should. And it's kind of complicated. One barrier is signing up for SNAP is difficult. So you really need some assistance with it, especially if you're an older adult and you're not very tech savvy. Secondly, a lot of older adults feel like they're taking away from other people when they use SNAP benefits. And so there's some of that stigma as well. They're very, generally speaking, older adults tend to be very giving people. And so it's just an interesting phenomenon. And then consider working with agencies to start a food prescription or distribution program. I'd say I've learned a lot about that, and I would only do that if you're very connected to the community. It's taken me years to have relationships with the community on the level that I do to be able to even start something like a food prescription program. But there are especially if you have a food bank in your region, then that could be a great partner for this sort of work. These are the publications I had alluded to that we've published on that look at dietary preferences within our community, our focus group information. And then I had mentioned that we have a pending publication in the Journal of Nutrition and Gerontology. So I put some references and resources in here, my contact information, and I'm happy to stop sharing and just discuss